So, good evening, everyone, and I welcome all of you to this webinar, which has been organized for during the Thyroid Awareness Month by the Indian Thyroid Society. And we have organized this webinar to create awareness about various aspects of thyroid disorders. So, we have kept topics like that where we will be discussing about the year in thyroidology. We'll also be discussing about other topics in thyroid, including the subclinical thyroid disorders, congenital hypothyroidism, and also about the thyroid nodules. And also, we are also discussing the various other things like how do we treat the nodules and other things in the panel discussion as well. But the most interesting thing is also there, that is the quiz, which everybody waits for. And this quiz, which is organized today, can be attended by all the delegates. We request only the endocrine faculty not to attend the quiz. All the other people are free to attend the quiz. And the Indian Thyroid Society will be giving the certificates for all the winners. So, with this, I welcome our president, Dr. Krishna Sheshadri. Dr. Krishna Sheshadri is our Indian Thyroid Society president, and he will be giving an overview of today's program and overview about the ITS.
Thank you, Pramila. Thank you, everyone. Thanks. Welcome. And as we celebrate the Thyroid Awareness Month this year, I'm happy to help kickstart the programs for this year. We are very proud and really gratified to see the response to our programs. The thyroid Indian Thyroid Society is somewhat different in than a specialty society. It's subspecialty society, meaning that it is designed to make sure that many people who are interested in the in disorders of this particular gland, whether they are endocrinologists, endocrine surgeons, cytologists, cytopathologists, physiologists, anatomists, that they can find a forum for expression of their interest, improvement in their skills, increasing the awareness about the gland, promoting research, but also importantly, improving collaboration among people while doing this. So this is the reason that the ITS exists for. It exists to be a vehicle for the promotion of knowledge, skills, and research about the thyroid. And we have done that, and today's meeting is is an important way we do that. We are starting with a overview. We are doing a review of the research advances in the last year. We have some tremendous experts who have contributed, including our past presidents, who are here today to share with you the knowledge of the thyroid. We have some exciting things that are coming up in this year. We are making our presence felt in social media. I think yesterday we saw the launch of our first Insta Reel, but importantly, these are coming out in various local languages. If you are interested in contributing to small pieces of thyroid knowledge in your local language, please contact Dr. Mohan Shenoy. He will share his thing here. He is the secretary of the social media committee. Secondly, we are trying to take the traditional patient care route, which is patient information route, which is all India radio. That you will see a lot of those campaigns this year. These are ably headed by our past president, immediate past president, Dr. Shashank Joshi. You will see some new guidelines that include laboratory and as well as multinodular goiter, T3 usage, thyrotoxicosis coming out this year. We are kickstarting our revision of the textbook. Also, a new program we hope to see by the ITS meeting this year, which will be the thyroid's self-assessment program, where there would be an expert compilation of self-assessment questions that anyone can do and test yourself against your peers. So this seems, and thanks to Pramila and her colleagues who have taken this monthly thyroid meeting to new levels. While the quiz is a great draw, I want to sort of remind you that you have the wisdom of tremendously knowledgeable and experienced experts who will otherwise not be easily available for you in your institution or your city available to you. Please make good use of these. They're more than the knowledge, the expertise, and the wisdom that they bring to you are tremendous. With this and a call for including more and more people who are one as Thomas More once said, unsung and maybe blooming in the desert and not be seen regularly on national media to be brought to the forefront, but also to call upon different specialities to be represented in this particular meeting. We have no egos. We will learn from everyone, and our purpose is to learn through everyone. I think that is very very important, and I hope that this sets a tone for the activities for this year. Thank you, Pramila. Thank you, everyone, and I hope that this meeting is useful for everyone who's attending today. Thank you so much.
So thanks, Dr. Krishna. And with this, we start our webinar for today. And I hand over to Dr. Ganvi to start the proceedings for today.
Good evening, everyone. We shall now start our webinar with a very exciting topic that is here in thyroidology. It is always good to be abreast about the latest advancements in thyroid health and research. And to chair the session, we have two eminent chairpersons with us today, Dr. Joe George sir and Dr. Kumaravel sir. I request the tech team to display the CV of the chairpersons. So, Dr. Joe George sir is the Senior Consultant Endocrinologist and Director of EndoDab Group of Institutions. And Dr. Kumaravel sir is the Director and Consultant Endocrinologist at Alpha Hospital and Research Center, Madurai. I now request the chairpersons to introduce our speaker, the ever-inspiring Dr. Beatrice Madam.
Respected Krishna sir, and thanks for the whole ITS team for bringing all of us together. I think we have an interesting talk on year on thyroidology. For that, we have none other than Dr. Beatrice Annie, and she is currently additional professor and head department of endocrinology, Nizam's Institute of Medical Science, and she has won Dr. Anil Sheth Award in 2021 from Endocrine Society of India. She's a gold medalist in DM Endocrinology 2016. She has gone APA gold medal in medicine, and she has authored chapter title Endocrine Disruptors in Endotext. And I think we over to Dr. Beatrice.
A very good evening to all. Thank you, sir, for the introduction. So this year in thyroidology, there's been a lot of research which has gone on in thyroid disorders. So I have just picked up a few articles which I found was interesting, and I would just give you a brief overview of these research articles which have been published in the last year. They may not be extensive, but then these are certain articles I thought would be of some use for us in our practice. So I have grouped them like this. So the progress in hypothyroidism, hyperthyroidism, and in thyroid malignancy. So to start off with hypothyroidism, so the first question is, are population-based TSH cutoffs enough? So ever since we've been using TSH to define thyroid disorders, so we use the reference ranges which have been documented in a apparently normal reference population. So we use the TSH range between the 2.5th and the 97.5th percentile of the observed values in a reference population. But if you notice, there will be a lot of inter-individual variation, although the intra-individual variation is not much. This is because every individual has his or own unique HPT axis set point. So there is a specific TSH concentration corresponding to an optimal function of the thyroid gland. And this high inter-individual variation can be explained by genetic factors. So while we use these current cutoffs, so this may be enough to diagnose overt disorders, overt thyroid disorders, but what about subclinical disorders? So this is an article which was published in the Thyroid. So this was about personalized TSH references. This was a genetic and population-based approach in 3 independent cohorts. So they have, these are cohorts which have undergone GWAS. So they have looked at certain single nucleotide polymorphism, and they have brought out a polygenic score in which they have included 59 genetic variants. And this was used to calculate a genetically determined TSH reference range in a thyroid disease-free cohort, which is about 6,000 people. And the results were validated in a second independent population-based thyroid disease-free cohort, about 3,000 people. And this was again validated. So the potential clinical implications were assessed in a third independent population-based cohort, which includes individuals without thyroid disease, as well as individuals who were on thyroxine. The findings of the study was interesting because there were a few clinical implications for the study, because based on these TSH reference ranges, up to 24 to 30% of individuals who were previously classified as having subclinical hypo and hyperthyroidism, when using the population-based TSH reference ranges, they were reclassified as euthyroid when these genetically determined TSH reference ranges were applied. So individual genetic profiles, they have the potential to personalize the TSH reference ranges, and they can have effects on reclassification of diagnosis and the levothyroxine prescription. So this is about this particular study. Going on to the management of hypothyroidism. So are we doing enough? So we'll talk about this hypothyroidism and type D personality, which are the results from the empathy study, which was a cross-sectional international online patient survey, which was published in JCEM. So in this particular study, they have looked at the prevalence of this particular type D personality. So what is type D personality? It is characterized by a predisposition to pessimism, worry and stress, and there's something called as a negative affectivity and social inhibition. They have used this particular questionnaire, which is called as a type D scale 14 questionnaire, which is a self-administered and a validated instrument. And this can figure out who has a type D personality. And this again has been divided into the negative affectivity and the social inhibition. So based on this, they have looked at the prevalence of this sort of type D personality in patients with hypothyroidism. Now, why is this important? The context was this, that about 10 to 15% of people with hypothyroidism, they experience persistent symptoms despite achieving biochemical euthyroidism. And type D personality, which is a vulnerability factor for general psychological distress, is associated with poor health status and symptom burden. But this particular entity has not been studied in people with hypothyroidism. Could this be a reason why people have persistent symptoms? So this is what was being studied in this particular study. And this was a multinational cross-sectional survey, and it was an online questionnaire which was administered to individuals who had self-reported and treated hypothyroidism. So the main outcome measures was to see if what is the prevalence of this type D personality among people with hypothyroidism, and what is the relationship between this type D personality and the respondent characteristics, and does this type D personality have an effect on hypothyroidism related patient reported outcomes? So this is what was being studied in this particular study. This, surprisingly, the prevalence of type D personality in hypothyroidism was an astounding 54%. And this was almost equal to diabetes. So this type D personality is not very unique for hypothyroidism because it can be seen in any sort of chronic illness. But in hypothyroidism, the prevalence was quite high, almost as much as diabetes. So, and there was also statistically significant association between type D personality and anxiety, depression, somatization, poor control of the symptoms of hypothyroidism by medication, and there was dissatisfaction with care and treatment of hypothyroidism, and a negative impact of hypothyroidism on everyday living. So this is basically a type D personality. It's not result of hypothyroidism, or its treatment. But the poor experiences often described by people with hypothyroidism, the pre-existence of this type D personality may sort of color the perception of the patient experience with hypothyroidism. So with this background, let's go on to something called as the medically not yet explained symptoms in hypothyroidism. So this is a distinct entity. It's called MNYES. So medically not yet explained symptoms, which means that the patient presents with some vague complaints, but despite adequate examination and evaluation, we are not able to get a explanatory structural or other specified pathology. And this patient has persistent physical symptoms. It's not in the mind. We cannot brush it under the carpet saying this is all in the mind. The patient is pretending or is just feeling that. No, the patient has true distress because of this medically not yet explained symptoms in hypothyroidism. But this has not been specifically studied in hypothyroidism. But in general, whatever is known about this MNY is, when we extrapolate to patients with hypothyroidism, it is estimated that about sort of 20